Hello everyone, I'm Christopher Kent, Professor and Director for Scholarly Activity at Sherman College of Chiropractic, USA. My paper today is Prevalence of Abnormal Findings in 686 Patients Referred for Cervical Spine and Lumbar Spine MRI Examination by Doctors of Chiropractic and Potential Neurological Consequences Associated with Vertebral Subluxation. Our study was a retrospective analysis of cases that were referred for MRI examination by doctors of chiropractic. These cases were sequential and consisted of 325 cervical spine and 361 lumbar spine studies. 325 magnetic resonance studies of the cervical spine were reviewed, and 91%, or 325, presented spinal abnormalities. Only 28 of the 325 had no abnormalities noted on the report. 35%, or 113 of the 325, had evidence of disc degeneration. 101 or 31% had disc bulges, and 61 or 19% had central herniations, 44 or 14% had paracentral herniations, and 4 or 1% had disc herniations noted where no directionality was indicated on the radiology report. In the lumbar spine, 361 reports were reviewed. 89% presented with spinal abnormalities. 70%, or 251, of the 361 cases had evidence of disc degeneration. 146, or 40% of the 361, indicated disc bulges. 10, or 3%, had anterior disc protrusions. 57, or 16%, a central disc herniation. 13, or 4%, a lateral disc bulge. 11, or 3%, a lateral herniation. And 44, 12%, a paracentral herniation. Of the cases reviewed, 24, or 7%, indicated borderline canal stenosis. This slide provides us with the prevalence of abnormal spinal curves per region and in total. In the right column, you can see that an exaggerated curve was reported in 3% of cases, a straightening of the curve in 23%, reversal in 4%, a dextroscoliosis in 2%, and a levoscoliosis in 3%. Alterations of spinal curves reported on MRI have to be interpreted with caution because the classic method for assessing curves is weight-bearing radiography. In these cases, the patient was lying supine in an MRI scanner. Degenerative cervical MRI findings from 325 reports indicated that disc degeneration was present in 113 or 35% of cases. 15 cases, or 5%, had non-specified degenerative disc disease reported. Arthrosis of the Luschka joints was noted in 2 or 1% of cases. Osteophytes in 54 cases, or 17% of the total. And posterior ridging was seen in 21 cases, or 6% of the total. Here we see a summary of the prevalence of degenerative changes in cervical MRI findings per segment. It's interesting to note that the area of degeneration and the prevalence are not homogeneous. In other words, we see degenerative changes in different places on different individuals. And those who argue that degenerative disease is simply a byproduct of normal aging would be advised to note that these differences suggest that there may be biomechanical etiology. So in degenerative disc disease, you can see the distribution was greatest at the C5, C6 level, 87, 69 at C4, C5, and 113 of the 325, or 35%, exhibited degenerative disc disease. Similarly, osteophytes were most prevalent at the C5, C6 motion segment. A total of 17% of cases demonstrated osteophytes, and posterior ridging, another manifestation of degenerative disease, was seen in 6% of cases. This chart shows the cervical disc lesion distribution in the 325 cases, and as you can see, 15 cases, or 5%, had a central disc bulge, 19% a central herniation, 31% a disc bulge, directionality unspecified, 1% had a disc herniation with directionality unspecified, and 14% had a paracentral herniation. This chart shows us the prevalence of disc lesions in cervical MRI findings by the segment. And once again, we can see that central disc bulging is most prevalent at C5, C6, and that 5% of cases reportedly had central disc bulges. The C4, C5 level had the highest prevalence of central herniation, visible in 19% of cases. Disc bulges were seen at various levels. You can see 26 here at C3, C4, at C4, C5, 42, and again, the highest prevalence is at C5, C6, where we had 55, and a total of 31% of the total had disc bulges reported. Paracentral herniations were most prevalent again at C5, C6, with 20 noted, and a total of 14% of cases had paracentral herniations. Lumbar MRI findings from 361 narrative reports demonstrate very high levels of prevalence. Disc degeneration was seen in 70% of cases, facet joint arthrosis in 11%, osteophytes in 4%, anterior disc protrusions in 3%, 16% central herniations, 40% disc bulges, 4% had a lateral disc bulge, 3% had a lateral herniation, 12% had a paracentral herniation, and 7% had borderline central canal stenosis. Once again, we can see the distribution of degenerative changes in the lumbar spine occur at different levels, at different motion segments. We can see that degenerative disc disease in this cohort was most prevalent at the L5-S1 level with 167 cases. 70% of the total had degenerative disc disease at one or more levels. Facet joint arthrosis was most prevalent at L5-S1 with 18 cases. 11% had evidence of facet joint arthrosis, and osteophytes were seen in 4% of cases. This table summarizes the prevalence of disc lesions in lumbar MRI exams, and as you can see, anterior disc protrusions were noted in 5 cases at both L2, L3, and L3, L4, with a total of 3% of cases reportedly having anterior disc protrusions. Disc bulges were most prevalent at L5-S1 with 82 cases. Secondly, L4, L5 with 54. A total of 40% of cases reported the presence of a disc bulge. Central disc herniations were most prevalent at L4, L5. 16% total reported central herniations. Lateral disc bulges were most prevalent at L4, L5. Total of 4% of the subjects examined had lateral disc bulges. Lateral herniations occurred most frequently at the L4, L5 level, with 3% reporting, and the paracentral herniation occurred most frequently at L5S1 with 19 cases and a percentage of total of 12. Let's discuss how these changes may be associated with vertebral subluxation and what the neurological consequences may be. In Stevenson's 1927 chiropractic textbook, subluxation was defined as the condition of a vertebra that has lost its proper juxtaposition with the one above, the one below, or both to an extent less than a luxation, which impinges nerves and interferes with the transmission of mental impulses. So we can see that there are multiple components to a vertebral subluxation, not merely misalignment. Mechanical and degenerative changes associated with vertebral subluxation may result in a variety of neurological consequences. So let's take a look at some illustrations from this little book, Magnetic Resonance Imaging of the Lumbar Spine, which I think will help to demonstrate these quite clearly. If we take a look at this close-up of the intervertebral foramen, we can see the area of the pedicle here. We can see the nice red bone marrow. We can also see the facet joint. And if you look closely, you can actually see the membrane. You can also see each articular process. This little yellow structure is the ligamentum flavum. Here's the nerve root. And here we have blood vessels, these dark things. And of course, the body has surrounded the nerve root with fat to help protect it. Here we can see the area of the intervertebral disc, and out here, the annular fibers. On the other hand, if we look at a rather severely degenerated segment, we can see the decreased interosseous spacing between the vertebral bodies, and we can also see the deposition of this yellow degenerative material where we have an osteophyte developing. We can also see that the ligamentum flavum looks quite different than the ligamentum flavum in the preceding slide. It has become corrugated and hypertrophied, and we can see entrapment of the nerve here. If we move down, we can see more advanced degenerative change here with fissuring of the intervertebral disc and the osteophyte causing impression on the nerve. Some of these illustrations are from my text, Case Studies in Chiropractic MRI. So let's talk a little bit about the MRI sequences that have been employed in the images we're going to be looking at. T1 weighted images tend to demonstrate marrow fat with increased signal intensity, whereas increased signal intensity on the T2 weighted images is associated with water. A well-hydrated disc will give us good signal on this sequence, whereas a desiccated disc will demonstrate decreased signal intensity. We can also see the CSF, which gives us a myelographic sort of appearance, and we can also infer the presence of an inflammatory process utilizing this sequence. On the left, we can see a T1 weighted image, and what I'd like you to note at the anterior aspect of the L5S1 area is the decreased signal intensity. Notice that we're getting a nice bright signal back here from the marrow fat, whereas there's decreased signal intensity. Here we can also see a thinning of the L5S1 intervertebral disc. If we look at the T2 weighted image, that kind of tells us the rest of the story, in that the L4, L5 disc, which looks pretty good on the T1 weighted image, demonstrates desiccation. There's decreased signal intensity and also disruption of the internal architecture of the disc. Notice that where we saw decreased signal intensity on the L5S1 region, we have increased signal here and we can also see disruption of the disc and a little high intensity zone here. This suggests that we have an inflammatory process. This isn't the same patient, obviously. I matched it as best I could to a cadaveric specimen, but as you can see, we have reasonably good disc spacing at L4, L5. At L5S1, the disc is severely degenerated. The reason this is so significant is because this patient had originally been labeled a malingerer. The claim was that the disc thinning evident at L5S1 was normal aging, and that the pain that the person was suffering was not of dermatomal distribution, therefore not likely associated with a disc lesion or nerve root compression. Well, on this film, we saw that there is evidence of increased signal on the T2 weighted image here, desiccation and disruption of the disc, the high intensity zone. We very likely have an inflammatory process going on here, and that's what's causing the pain, not nerve root compression. If we take a look at the staging of spinal degenerative disease, grade 1, normal, we can see at the arrow the nerve, we can see the patent intervertebral foramen. We can also see that the posterior joints are in juxtaposition, they're well aligned, the soft tissue structures are as they should be. As disc degeneration progresses, we start to see that we have malalignment at the posterior joints. We're starting to see some end plate sclerosis, and there can be some minimal compression of the nerve root. We know that as little as 5 to 10 millimeters of mercury of pressure can interfere with the venous drainage, causing swelling, and can also decrease the amplitude of the compound action potential by 40 to 60%. So again, on the MRI study, we can see at the arrow the narrowing of the IVF. Grade 3, they call this mild. We're actually starting to see some rather robust posterior joint degenerative changes. We can also see the developing end plate sclerosis, the entrapment of the nerve, and on the schematic you can see it's looking a little bit swollen, likely as a result of blockage of the venous drainage. 4, they call this moderate. Again, we can see more swelling here on the schematic, very difficult to visualize the structure here. And grade 5, severe, where the IVF is virtually non-existent, and we can see the entrapment of the nerve root by the osteophyte. A weight-bearing view of the cervical spine, and the only abnormality reported in this particular case was straightening of the cervical curve. But if we have a little more meticulous analysis, if you draw a line along the posterior aspect of the vertebral bodies, George's line, if you're into eponyms, you can see that down here there is some posterior ridging occurring. You can see that this disc is thinner than the one above and the one below. And this too was a person who was purportedly a malingerer. The film was read as normal, and when it was pointed out that there was degenerative change at this motion segment, the claim was that it was merely normal aging and not likely related to their problem. Well, if we look at the schematic of a healthy cervical spine with a nice, robust cervical curve, notice if we draw lines along the inferior aspect of each vertebral body and between the anterior and posterior tubercles of atlas, the lines converge posteriorly. But on the films you just saw, the lateral indicated some significant biomechanical abnormality as well. You can see the lines crossing here between atlas and C2. You can see that we actually have divergence rather than convergence at the level where the degeneration is apparent. So again, here's a cadaveric study, and what I'd like you to notice here is that the distribution of the degenerative material is different from segment to segment. Again, we can see the nice red marrow here and here, but we can see the yellow degenerative material here. We can see what almost looks like a little slice of pizza here at the anterosuperior aspect of C3, and the degenerative end plate changes that are occurring here. If we take a look at a T2 weighted MRI of that same patient, suddenly her pain makes sense. We can see at the involved motion segment we have increased signal intensity on the T2 weighted image, suggesting edema and inflammation. We have decreased signal intensity here at the disc, which was thinned, as we could see on the plain film. Perhaps more significantly, we see a change in the contour of the CSF signal posteriorly, and cord compression, which can develop as the degenerative changes progress, can have some rather significant consequences. This is a relatively healthy spine. You can see the spinal cord and the CSF signal. You can see the nice hydrated discs. But if you look very closely, you can see that we're starting to see some degenerative change anteriorly here. We've got a little bit of uplifting of the posterior longitudinal ligament here and here, but all in all, not too bad at this point in time. If we take an axial image of the same individual, you can see the cord centrally, you can see the CSF, you can see the anterior root, the posterior root, and the dorsal root ganglion here, vertebral body, lamina, spinous process. What I'd like you to note on this that is often overlooked is that we can see very clearly the lines of demarcation between the various layers of back muscles. See how nice that delineation is? Well, if we take a look at another case with degenerative change, the differences from what you just saw are rather striking. Along, if we draw a line in our mind's eye along the posterior aspect of the bodies, we can see a little bit of uplifting of the posterior longitudinal ligament here. Here we can see herniation, uplifting of the PLL. We can see a rather dramatic change in the contour of the CSF signal at these two levels. At this level, we can actually see some compression of the spinal cord. And if we look at the transaxial image, again, we can see the herniation very nicely here. We can see an osteophyte here, a spondylotic bar, which we don't see on the contralateral side. And we can also see loss of those various layers of the back that were easy to see in the preceding case. If we look at a motion MRI study with advanced degenerative change, we can appreciate how the osteophyte is causing impression on the anterior aspect of the spinal cord. It almost looks like a myelogram here, and it's something that is quite obvious. Take a look again. A couple levels are involved. Not a good situation. There are a variety of putative neurobiological mechanisms associated with vertebral subluxation. First, we have cord compression and adverse cord tension. These may be associated with alterations in curves and may be associated with a variety of pathologies. Nerve root compression can occur as the spinal roots are exquisitely sensitive to compression block. As little as 10 millimeters of mercury of pressure can produce a decrease in the amplitude of the action potential, the value sometimes falling to 50% or even less of its original level. Local irritation may occur, and this local irritation may be associated with an inflammatory process where we have inflammatogenic chemicals such as histamine and substance P, which can give rise to a chemical radiculitis. We can also encounter vertebral artery compromise, particularly at the craniocervical junction. Autonomic dysfunction is often associated with vertebral subluxation. Coherence and oscillatory patterns associated with biological oscillators may be compromised, and disafferentation and neuroplasticity may be noted. Disafferentation occurring when there is abnormal afferent input affecting the body's information concerning internal and external environment, and neuroplasticity, where both functional interconnectivity changes and actual anatomical changes may take place in the brain. Some of the limitations of our study are that due to de-identification of the narrative reports, gender was not obtained for each subject. In addition, the original reports did not include the subject's birth date, making it impossible to calculate and report age, and no history or diagnosis was available, so we were confined to the description of the clinical findings on the MRI. Finally, I'd like to acknowledge Dr. Kathleen Costello, my research fellow, who was invaluable in preparing this, and the Foundation for Vertebral Subluxation, which founded the study and provided IRB services. Thank you very much for your attention. I hope you enjoyed the program.